I'm Kieran Anderson, Group Publisher here at Applied Radiology, and we are in the Canon booth here at RSNA 2024. I had the pleasure of standing here with Dr. Reza from UC Davis. And Dr. Reza, thank you for taking the time to join us.
Of course, thank you so much for having me.
Dr. Reza just got off stage in the Canon Theatre where you were sharing some information about some of the latest work you're doing in cardiac thoracic imaging. Is that correct?
That's correct, yes. So we got the Canon scanner, the new Insight edition version, about 2-3 months ago. And we've been working it in various type of patients populations, pediatric, adult cardiac imaging.
Excellent. Maybe you could tell us a little bit about some of the features that you find most impressive.
Right. So when you do cardiac imaging, the scanner that you really need is the scanner which is sharp enough, which is fast enough, and which is easy to work with. Otherwise, if you have the best scanner which is sharp and which is fast, and it's so complex to work with, you're going to find a few techs who can work with it, but the rest of the techs or your personnel avoid using it. So I think this is the key element for us, that's having the scanner which is sharp. And when I say sharp, is that it produces the images with the highest resolution possible. And fast means that the images are motionless.
Right.
So that's really the key to capture the small structures within the heart, which is as small as 1 to 2 millimeters.
So as you think about some of the things with the 1024 matrix, one of the things I'm interested in is how has that changed the difference you're seeing in CAD-RADs?
Yeah, so the CAD-RADs is really depends on the interpretation of the stenotic lesion in coronary arteries, right? So to some extent it's still subjective, meaning that it depends on the experience of the radiologist. It also depends on the software that you use to calculate the area of stenosis. So the input image is really important. So the sharper image and the more resolution that you get, and you put it into the software, whatever software you use for calculating the stenosis, and your eyes that are going to look at that image are going to eventually define which CAD-RADS category is the best for that lesion. So there are studies that already show that the high resolution images may downgrade the pre-existing CAD-RADS category which was assigned to one specific lesion. So that's a huge thing for future, and then for overall better interpretation of the CTA coronary artery images. That changes the management. The patient who was sent, for example, to the cath lab for further evaluation with this method may not need, at least for some time. So that's really a huge thing for the patients and for us as physicians to keep the resources for patients who really need it.
Right, no, that makes an awful lot of sense. And did you find that there was a learning curve required in terms of kind of getting up to speed, also adjusting to the image improvement with this technology?
Well, there's always a learning curve, right? Especially in evolving environments that you have diverse faculties in your group. There are ones that are more experienced and one that are just recently joined your group. Maybe they were in a place that they didn't have this technology. But I would say that the learning curve is pretty quick. So almost you don't see anything. It's like looking at an image which is better and better quality and prettier. So it's actually after some time you don't want to go back. So the problem is not having a better technology and looking at nicer images. The problem is that when you are now sometimes have to work with the scanners that don't have that capability, then you may not like it, or you may need to change your thresholds. So I think we found that as the challenge to some extent.
To some extent.
Right.
And as you think about other use cases for this technology, I know that you're initially using it in cardiac within your institution, and that's kind of your area of specialty, but do you see applications in body or lung or anywhere else?
Yeah, absolutely. I think we do the wide range of images in cardiothoracic in our division. So we do not only cardiac images, we do cancer images of the lung and the mediastinum. Our colleagues in body imaging also use that technology. I think the peak reconstruction, which is that super resolution or high resolution, it really makes difference when you are scanning the small structures which have inherent low contrast. For example, a small lesion in the pancreas. Our colleagues in body imaging were showing me it has improved their detection confidence.
And would you say that there are any specific patient populations that might benefit the most from this technology?
I think all the patients will benefit from this technology. This technology is not introducing much more radiation
Right.
because it's based on deep learning. So you get the super resolution, not based on detection, not based on the detector size. You get it based on the reconstruction mode. So you get a super resolution as low as 0.25 millimeters, but the actual source images that you input into the algorithm is 0.5 millimeters. So you are not adding the dose, but you are actually increasing the resolution. So I think all the images will benefit. They are still working on some, for example, lung reconstruction for this method that is going to be available soon. But for the rest of the mediastinal window and other structures that we've used, we kind of like made it as a default.
Anything else you'd really add about this technology since you've brought it into UC Davis, in terms of, how you're using it, what your colleagues think about it, maybe even what patients are saying? I mean, it's a fast scanner. They're on and off much faster, so there has to be some benefits there for them as well.
I would say the patients populations who benefit the most are going to be the patients who are really sick. They really don't want to spend so much time on the scanner. We want to have the streamlined workflow. Once the patient is on the table, till they are out of the scanner and go to their room in the hospital, or they are out, they go back home, you want to really shorten that time. So we've seen already the satisfaction in that turnaround time. And also, I would say in patients who are smaller patients, like pediatric patients that we do cardiac imaging on, the anesthesiologists, for example, who work with them and bring them over there to the scanner, they really appreciate the faster scan, the scan time, and the less time that they have to spend, and they have to work with the patient on site at the scanner. So there is more satisfaction from the patient side, from the supporting team, that sometimes they come with more complex cases. And also, I would say, to our technologists, who are the ones actually who are working with this scanner for the most. So I think overall, it's a beneficial chains of like different groups who are going to benefit from this technology. It's not just the radiologists who are going to look at the images. I think that's the beauty of this technology.
I think that's great. And I'm glad you mentioned the technologists, because I mean, as part of the workflow, they do so much of the work too, right? And so it has to make sense for them. And so far, so good.
Yeah. Then when we talk about getting a new equipment, we get their feedback and we say, hey, what do you guys want?
Right.
And most of the time, they don't care that much as we do for the resolution and how pretty the images are. They want a scanner which is user friendly and it's not too complex. The complexity should be solved by the streamlined workflow. So that's, I think, was the challenge to get a new scanner. And when we were asking, what do you guys need? They said, give us a scanner that all of us can work with it,
right.
Not just a few of them.
Well, that makes an awful lot of sense. And as you sort of think here, as we're here at RSNA, obviously you've got colleagues from around the country, maybe even the world here, some of them who might be looking for a new scanner. What do you say to them as you think about your experiences with this new Aquilion scanner from Canon?
So I speak from cardiac imaging and cardiothoracic imaging parts, not the entire radiology. There's so many radiologists vast, and there are so many colleagues that can look at what they need from the scanner in different ways. From cardiac imaging specifically, I think this new scanner from Canon is a really a game changer. It used to be a more a dominant vendor in the market that the best institutions would go after to have the cardiac imaging center which works for them with the highest quality. But I think having this scanner you have this scanner, you can do all your cardiac exams with the highest quality which you want for your patients and for yourself and for your colleagues. So we are very happy with our experience so far.
That's great. Well, Dr. Reza, I want to thank you again for taking a moment to speak with us here at Applied Radiology, here at RSNA, and wishing you a fabulous day and the rest of the show.
Oh, of course. Thank you so much
Thank
for
you
having
for
me.
your time, sir.
Yeah, of
All
course.
right.